All right. So just so you guys know, these concepts can be found in several books. Your Iggy, Volume 1 and 2, as well as your Fundamentals book. I also used the new textbook for pharmacology that we're trying to determine if we want to adopt. You all can use your textbook, but I will mostly review Mosby's for that information, for your information. That's what I would do. Mosby's and also that other textbook, but mostly Mosby's if it asks you anything about a drug, a medication. I think corticosteroids, there's a concept on there about that, and they wanna know about the side effects. So I would definitely look at your Mosby's for that. It spells it out, I'm sure, pretty good based on some of the conversations I've had with you all. I'll touch on some of these topics in a little more detail as much as possible, but for the most part, I will also be directing you to where you need to go and read the information because it can be quite a bit, and it's going to be a matter of you really sitting there and taking some time and going through it. So those are the resources that I need you to look at. And to be quite frank, even Googling a few things here and there is not a bad thing either. Because there's quite a bit of information that can be found that way as well. Let's see, those are the resources. So the first one I want to look at is osteomalacia priority. And that is on, it's somewhat kind of vague, but I'm thinking they're talking about the priority collaborative issues. So I believe that was 1016, page 1016 for osteomalacia. I wanted to get my page numbers beforehand also because it will help us to kind of get through this a little quicker, knowing what we had to look at. Now, if you look on page 1016, there is a table 50-1, and it talks about differential features of osteoporosis and osteomalacia. So I will go ahead and take a look at this particular table. For the definition, they talk about osteoporosis being a decreased bone mass caused by multiple factors. You know, one of those factors could be, for example, hypoparathyroidism, because you know with hypoparathyroidism, that's where you're dealing with calcium and phosphorus. Remember we talked about with the hyper or hypoparathyroidism, we talked about osteoclastic and osteoblastic activity, bone destruction, and also bone building. But with osteomalacia, we're talking about bone softening caused by lack of calcification, right? And so then you ask the question, why is there a lack of a calcification of bones in this case? Well, it's because these patients are not able to absorb, they cannot absorb calcium. But do you all know what vitamin it takes to absorb calcium?
Vitamin D.
Vitamin D. So no vitamin D, no absorption of calcium, soft bones. All right. Now, osteoporosis is a major global health problem. And in the less affluent or famine countries where there's a lot of famine or hunger, Many individuals have both osteoporosis as well as osteomalacia. So these poor countries and whatnot. And it results from poor dietary deficiencies. All right. And so again, osteomalacia, loss of bone related to lack of vitamin D, because you know you need vitamin D to absorb calcium. And of course, this causes a softening of bones. So vitamin D is needed for calcium absorption in the small intestine. And as a result of vitamin D deficiency, normal bone building is disrupted, will not take place, right? And calcification does not occur calcification is needed to make the bones harder, all right? And so again, make sure you read that table as well so you can see the comparison. All right, so don't want to spend too much time. Let's see, which one is this one? There's also something on page 96 and 100 in volume 1. I don't remember specifically what that was. 96. Page 96 and 100. Oh, you know what? Scratch that. The last pages I called out for the next topic, which is CBA, self-care. All right. So let's look at. All right. So for CBA, self-care, take a look at page 928. All right. Now, this particular page number I just gave you just gives you general information about CBAs, but it seems like I actually went to volume 1 of IGGI, page 96, to look at some of the self-care issues. So let me see what I noted in those areas. All right, so for CBA, we're looking at trying to increase the functional ability of your CBA patients, because as you know, when the brain is impacted by a stroke, then these patients will tend to have a decreased functional ability. All right. And so what we would like to do, or what we expect, is to increase the functional ability in self-care and other self-management skills with or without assistive or adaptive devices, you know, like canes, walkers, and whatnot. And so when we think about ADLs, activities of daily living or self-care activities, includes eating, bathing, dressing, grooming, and toileting. These are things that we may have to teach these patients again, all over again, after a stroke. And so what we want to do is encourage these patients to perform as much self-care as possible. You don't want them to become too dependent on you providing the care, because remember, the goal is to get these patients back into the community or into their home setting, and so that they can manage their own care. You always want to allow these patients time to complete their task as independently as possible. You don't want to rush these patients when allowing them to do what they need to do to take care of themselves. Don't hesitate also to collaborate with occupational therapy, because they can help you identify ways in which self-care activities can be modified. In other words, they can give you the tricks to the trade on how to make performing activities more simpler for your patients. And this, of course, will help them to function more independently, and it might also, or we hope that it decreases any frustration, because it can be pretty frustrating. I mean, just imagine you were pretty independent before your stroke, and all of a sudden now you're depending on people. So hopefully that will help these patients to lessen their frustration. So for example, and this is an example of what occupational therapy can teach you. If you have a patient with hemiplegia, and that's one side of the body is weak, right? What you teach the patient is to put the shirt, to put on the shirt first by putting the side or the arm that is more affected into the sleeve, and then you'll follow that up with putting the unaffected arm into that into the other sleeve. Also, slip-on shoes with Velcro straps may be recommended for some patients as well, because sometimes they lose their dexterity. And so we want to encourage the patients to practice and allow them time to be independent in the activities of daily living. All right. And the focus areas for patients with these types of disorders is bed mobility, ability to move up or move about in the bed, walking, transferring, dressing, grooming, active range of motion, and also communication. So take a look at page 96 on the left side of the page under increasing functional ability, and it talks about the different interventions. So take a look at that. That whole section, if you can, read that information. And I think it's something on page 100 as well. All right. On page 100, on the right side of the page, towards the bottom, it talks about self-management education. Talks about OT and PT helping the patient or teaching the patient to perform their ADLs independently. All right. And remember, we have to always determine if the patient assess their cognitive ability or capacity, because sometimes when patients have strokes, it does impact their cognitive system, and therefore sometimes they just can't even follow directions. Also, when we are written material should also be provided to these patients, but we have to make sure written material for the patient as well as their family members. But one of the things we have to make sure is that the information is at the appropriate reading level, because you guys would be surprised. There are a lot of people out there who are health illiterate or illiterate, so they're pretty illiterate and really can't read. They might be reading on perhaps an 8th grade or even lower reading level. So we have to make sure that the information is at their level of reading. We also want to, help the patient deal with, these life changes, allow them to verbalize their feelings and emotions as well. We want them to open up about their situation and to talk about ways to prevent worrying about their health concerns. So make sure you read that section. It's not really long. Read all the way up to healthcare resources. It's kind of like a few paragraphs, but they're pretty short. And again, that's on page 100 in volume 1 of IGGI. Page 96 and 100 is in volume 1 of IGGI. The next one is, let me mark that one off, go back to it. The next one is skin lesions, and it is talking about possible now, Kaposi sarcoma. And this one is on page 347. And hopefully you guys will have the ability to, as you listen to, if you decide to listen to this again, you can, pause, play, and, do it that way as you look at this information. And, give yourself time to read it, then come back to the voiceover and continue like that. So HIV would be in chapter 19, and I told you 354. Now, you all do realize that Kaposi sarcoma, or what we also call KS, it is one of the opportunistic infections for HIV, like PCP pneumonia, toxoplasmosis, cryptococcal meningitis, and whatnot. So, so take a look at page 354, starting with on the right side of the page towards the bottom, talks about restoring skin integrity. Impaired tissue integrity in AIDS may be related to Kaposi sarcoma of the skin, of also the mucous membrane and internal organs. So this is where Kaposi sarcoma can be found. And it is a form of skin cancer, and it can kill these patients. The lesions, they can be localized, but they can also be widespread. I've seen it where it's widespread. It's all over these patients' bodies. And it looks very gross. The large lesions, they can cause pain. They can also restrict movement, and they can impede circulation, causing open, weeping, and painful lesions. All right. As far as some interventions, Kaposi sarcoma does respond well to the antiretroviral medications. And as they take these medications, remember the CART medications for AIDS, as they take those medications, the lesions, they do many times disappear. And if they don't disappear, and I think I'm covering 2 of these, so bear with me. I'll tell you the other one that we get to. If the lesions do not respond to the antiretrovirals, then these patients can be treated with local radiation, also intralesional or systemic chemotherapy. So chemotherapy might be warranted as well, because again, this is a cancer. Also, they're treated with systemic interferon and cryotherapy or topical retinoids. Treatment of painful KS lesions include analgesics and comfort measures. We want to keep open, weeping Kaposi sarcoma lesions clean and dress them well in order to prevent infection. And of course, many of these patients who have KS, they are concerned about their appearance, and rightly so. I mean, you have these dark, brownish, purplish lesions all on the face, all on the body. I'm telling you, it's pretty gross. Sometimes makeup might be used to cover the lesion a little better, especially if it's located in the face. If the lesion is closed, not if it's open and weeping, you don't want to put makeup on that, because that would just make it worse, right? So if it is a closed kind of cancer, then you can apply makeup in those areas as well. These patients can also wear long sleeve shirts, but they may wear hats in order to help them maintain, their appearance, a normal appearance. Now, as far as a definitive diagnosis of KS, think about a biopsy, right? Think about a biopsy because you can biopsy the wound or the lesion. You can place it under a microscope, analyze it, and it will give you a more specific and definitive diagnosis for better treatment of this condition. So a biopsy would be very important here as a way to determine if it truly is a Kaposi sarcoma. All right, so that's all I'll talk about on that one. In the same volume of IGGI, page 57, I think it's the same volume, 578, let me confirm. All right, so on page 578 in volume 1 of IGGI, start reading on the left side of the page on 578 under breathing techniques. And read where it says, let's see. It starts off with diaphragmatic, the diaphragm or abdominal or pursed lip breathing may be helpful for managing dyspneic episodes, when these COP patients become short of breath. And so they actually provide you with a really nice demonstration, a chart 30-10, 30-10. And it provides a picture of someone doing pursed lip breathing. All right, tells you or shows you exactly how that is to be done. So go ahead and make sure you read that. I won't cover this now, but just go ahead and read that. Also, what I told you on the left side of this page under breathing techniques, like I said, read that. And beneath that one is, it talks about in diaphragmatic breathing, the patient consciously increases movement of the diaphragm. So read that little section as well. Let's see. Yeah, so read that section. And again, make sure you take a look at that chart. And this is pursed lip breathing for COPD. They basically do this in order to remove, make sure there's no, because in COPD you have that trapped air, right? And so with pursed lip breathing, it allows you during periods of activity to expel as much as possible that stale air, all right? Because you need fresh air. And this in this particular section, it does talk about the patient should not ever hold their breath, all right? And you're always inhaling before beginning any activity, and you exhale while performing the same activity. So again, just go ahead and make sure you read that. Let's see. So that's pursed lip breathing. The next one is, it says IM dash milligram per ml. Now, I cannot tell you if that is a math problem or if they are asking, because again, this is one of the vague ones in my opinion. I'm not sure if they are at least, or if they want to know, if you know, the amount of volume that can be injected in the intramuscular site. So let's see, so look on page 649 in your fundamentals book. And under, on the right side of the page, intramuscular injections. And down to the third paragraph, it talks about the angle of insertion for IM injection is 90 degrees. And if you go down a little further, it says muscle is less sensitive to irritating and viscous medications. A normal, well-developed adult patient tolerates 2 to 5 mLs of medication into a larger muscle without severe discomfort. So the magic number here is 2 to 5 mLs in a healthy patient. Now, for children, older adults, and thin patients, they can tolerate up to about 2 milliliters of an IM injection. So just read that section just in case it is talking about that. My other thought is, is it talking about a calculation, which you all do pretty good on your calculations, in my opinion. Because we may have to, we'll go over some of the, like the drips, because there was a test I gave you all that I think most of you missed that particular question, so we'll go over that. All right, so the next one is, the next one is Cushing's syndrome. So I'm actually looking at my slide on this one, but if you would like to go back to your textbook, page 1255 to 1257 in your IGGI textbook, volume 2, you can read about that information, Cushing syndrome, which is not a whole lot. Remember, Cushing syndrome is hyperadrenalism, hyperfunction of the adrenal glands. Let's see, 1255. Yeah, so if you look at this table on chart 62-10, talks about Cushing's disease, and by systems, it tells you what are some of the signs and symptoms to look for. For example, as far as general appearance, you have a moon face, a buffalo hump, a truncal obesity, when you're really heavy within the trunk area of the core. Also weight gain, because remember, with hyperadrenalism, the aldosterone system also kicks in. And remember, with the aldosterone, remember when we talked about the ROS system, aldosterone actually retains sodium. And if you retain sodium, then water follows. And of course, now you have a patient who is swollen. All right. And so also think about that. So if when the aldosterone system kicks in, which is a mineralocorticoid, these patients will retain a lot of sodium, meaning if you get a question to ask about certain characteristics or clinical features, then you know that these patients are hypernatremic or high sodium. These patients may also have, as far as cardiovascular symptoms, hypertension, frequent dependent edema, bruising, as well as petechiae. As far as skin symptoms, thinning skin, striae, and increased pigmentation. They also have a high chance in pathological fractures. So their bones will fracture spontaneously. The slow healing, because it does affect the immune system as well, when you're dumping all that cortisol into the bloodstream. So with Cushing syndrome, remember the adrenal cortex is what is dumping out a lot of cortisol. We also refer to this as hypercortisolism. Again, excessive secretion of cortisol from the adrenal cortex, not the medulla, but cortex. And it can be a problem with the adrenal cortex. It could be a problem with the pituitary gland. Remember, the pituitary gland is what creates the stimulating hormone ACTH, or it could be the hypothalamus, be a problem with any of those. And so whenever the body has an excessive amount of glucocorticoids, no matter what the reason is, metabolism and all body systems are impacted. And for that reason, this is why I want you to read those features on page 1257. So the reason why you see a characteristic truncal obesity called the buffalo hump or the moon face, the face looks round, almost like a moon, a shape of a moon, is due to that fat redistribution. There's also an increased breakdown of tissue protein. And proteins are used to build muscle. If you have a significant breakdown of protein, then these patients will have a decreased muscle mass. And if you have a decreased muscle mass, what happens to muscle strength? You become what? Weak. All right. And then you also have thin skin and fragile capillaries, and this is where you get some of the bruising and the striae symptoms as well. These patients, this condition also has an effect on the mineral corticoids. So there's an increase in bone density loss, which means these patients are more prone to fractures. And so you want to handle these patients with a draw sheet and not with your hands, because you don't want to break the bones. This condition also leads to an impact on your immunity or your immune system. When the corticosteroids are increased, the higher your cortisol levels, it has an effect on your lymphocytes. Remember, lymphocytes are used to fight the foreign invaders. It's part of your immune system. And so with an increase in corticosteroids, your lymphocytes are decreased. All right. It also shrinks organs that contains lymphocytes, such as your spleen and your lymph nodes. And also white blood cell cytokine, cytokines is part of the immune system, is decreased. So these patients, in essence, they become increased risk for infection. It also has an effect on the androgen production, which is increased here. This causes these patients to have acne, hirsutism, facial hair, and also clitoral hypertrophy. The clitoris becomes enlarged. Also, androgen production, it increases or causes an increase in your cortisol levels. And what this does is there's a disruption in the normal ovarian hormone feedback mechanism. So in other words, there's a decreased ovary production of estrogen and progesterone, the hormones. And this can cause either scant or infrequent menses as well. All right. So remember all this information I just told you about Cushing's, because it doesn't necessarily, and this is not a lot, it's in your slides. It doesn't give me a lot. This one is also under the slide, patients with pituitary and adrenal gland problems. This is an adrenal gland problem. Now, just as a side note, so you have hypercortisolism or Cushing syndrome or hyperfunction of the adrenal gland. You can more or less use those terms interchangeably. But remember, the opposite of that is hypofunction of the adrenal glands. And also these patients, you can refer to it as Addison's disease as well. Addison's crisis, when you have a decreased production of cortisol. So one is an increased production of cortisol. The other one is an increased production of cortisol. And the hyper, up, so increased production, hypo, down, a decrease. All right, so that's that one. Now, if you go into, we're talking about chemo side effects, and I would like for you to go to page 394, volume 1 in IGGI. And this one is a fairly straightforward one, so I probably won't go over this one, but you just have to go back and just read it. So if you look on page 395, actually, I'm sorry, go to page 395, volume 1, same volume. And so it talks about side effects of chemotherapy. So go ahead and read that section up to where it says distress thermometer figure 22-3. And it's very short, actually. It talks about how chemotherapy suppresses the bone marrow from forming blood cells, and so this leads to anemia. It can also lead to, it can impact your immune system. So these patients are neutropenic, thrombocytopenia, meaning low platelets, alopecia, anxiety, sleep disturbance, bleeding, impaired clotting. So make sure you take a look at that section as well. Not a whole lot, good amount of information to read. Or good information to read, not good amount. It's really a small amount. Moving right along. So it talks about CKD, missed dialysis, and more specifically about labs. And I referred to one of my slides on this one, and also on page 1404 in your IGGI. 1404. So on page 1404, on the right side of the page on the laboratory assessment, it will talk about the different labs that you should be focusing on a patient. If they miss dialysis, you know the effect that dialysis or renal failure has on body systems. And so when you don't cleanse the patient's blood and do those treatments, then they can run into a lot of problems. And so there can actually be some extreme changes in their laboratory values. So we're looking at things like their BUN and creatinine. We're looking at their electrolytes such as sodium, potassium, calcium, phosphorus, bicarbonate, hemoglobin, and hematocrit. And we also look at their GFR, glomerular filtration rate. Remember, the lower that number goes, the more severe the patient's renal failure is. I believe the value that it tells you that if it's greater than 90, it's not so bad. You actually are producing a fair amount of urine if your GFR is greater than 90. But it still doesn't mean that you're not in stage 1. It's just that because there's certain structural issues or other problems that can lead to kidney failure, like diabetes. But so if you're at 90 or greater, and they give you on this particular chart, don't know if I can find it now, but they give you a chart that talks about these different values that you can take a look at if you want to. It's on page 1399, table 68-6, and it talks about the glomerular filtration rate, stage 1, stage 2, 3, 4, and 5 is what you're looking at. And as I said, these patients are at risk still. So take a look at that. Remember, the magic number is 90, greater than 90, and you're pretty much good to go, but you still have to watch the patient. Of course, as you begin to decline, 60 to 89 or 30 to 59 mLs per minute, or 15 to 29 or less than 15, it becomes more severe. All right. Remember also, just in case you're asked, the glomerular filtration rate is probably used a little more often. You still do a BUN and creatinine to determine renal function, health, but the GFR is a more it's more specific because it's more individualized because it takes into account the patient's their age, the gender, race, and body size. So that's a whole lot more specific. All right. So anyway, so those are your labs that you want to focus on when your patients miss dialysis. All right. So in your IGI textbook, volume 2, page 868 to 70, it talks about Parkinson's disease and then ambulation. Let's see, so 868. Now, you know the main neurotransmitter that is implicated in Parkinson's disease is dopamine. That's the neurotransmitter that allows you to move smoothly, coordinated, and whatnot. And of course, when these patients have a diminished amount of dopamine, their movements become more erratic, jerky even. All right. So on page 870 in particular, lost my place. 870 in particular, under promoting mobility. The expected outcome for these patients will maintain optimal mobility and not experience complications of impaired mobility. So you want to be able to help them to ambulate without risk of falls. All right, so care of the patient with Parkinson's includes drug therapy, exercise programs, or physical therapy, and interprofessional collaboration in order to promote mobility and self-care and prevent falls or injuries. You know, they have that shuffling gait. When you look at these patients with Parkinson's disease, they have a shuffling gait. And with these different, with the collaborative function, or rather team, you want to make sure that your patients can ambulate in a way so as not to cause them any injuries. Also, look at chart 42-5. It talks about care of the patient with Parkinson's disease, and it's a few bullet points down. It talks about collaborate with physical and occupational therapists to keep the patient as mobile and independent as possible in ADLs. The next one is allow the patient time to perform ADLs and mobility skills, provide assistance only as needed. Implement interventions to prevent complications of impaired mobility, such as constipation, because these patients can become constipated because they're not moving very well, pressure injuries, and also contractures. So read those few items there as well. Now, remember, as I mentioned, dopamine being a neurotransmitter, it allows for a kind of refined, coordinated movement, such as picking up a pencil and writing. And of course, without enough dopamine, you see these patients kind of, they're shaking, you know, and not able to do that, perform that task very well. All right. Let's see. That's Parkinson's amylation. The next one is electrical burns. And this is in IGE Volume 1, starting with page 487. And so I'm going to have you guys read this one as well. Start on page 487 under electrical injuries. Read that one. And then on the next page, 488, on the left side of the page, still continue reading about electrical burns. And you can stop at around, stop before you get to radiation injuries. You don't have to read that part, but just stop there. Also read page 489, chart 26-1. This talks about electrical burns. So at the scene, you want to separate the patient from the electrical current. You want to smother any flames that are present. You want to initiate CPR because their heart may stop beating. And you want to obtain an electrical ECG or EKG because it can affect their conduction system of the heart because of that electricity. So go ahead and read that. Not a whole lot of information either, really. All right, so the next one is acute kidney injury, fluid overload. This one is on page 1394 in IGE Volume 2, 1394. 1394. If you look at page 1394, on the left side of the page, under physical assessment signs and symptoms, in the next paragraph where it talks about other symptoms of AKI are related to building of nitrogenous waste or BUN. They also refer to this as azothermia and a decreased urine output or oliguria. As AKI progresses in severity, the patient may have symptoms of fluid overload because fluid is not eliminated. Indications of fluid overload include pulmonary crackles, dependent and generalized edema, or what we also call anasarca, decreased oxygenation, meaning low peripheral oxygen or SpO2, or O2 saturation, decreased oxygen, I said that, confusion, increased respiratory rate, and shortness of breath. And you can also read chapter 11 for assessment of fluid overload as well. So go ahead and read that information also. So just look for those pulmonary issues. These patients can also go into heart failure as well. It can make their heart failure even worse because you're not excreting all that fluid. All right. Now, the next one is AIDS, Kaposi sarcoma, and we discussed that already, one of the opportunistic infections. I discussed, I think there was one talking about, let's see, how did they read? Talked about skin lesions, possible Kaposi sarcoma, and I think that one is talking about just the fact that you need to do a biopsy to confirm. And this other one, AIDS Kaposi sarcoma, I think in some of the reading I touched on some of the other information, but read page 354 to 55 of volume 1 for this condition, again, just to reinforce. Let's see, so thing keeps moving. All right, so in your, is that an IGI? Pre-op lab. All right, so on page 237, volume 1, it talks about pre-op labs. There are certain labs that are important for clinicians to draw before a surgery.
What page?
Let's see. Let me see if I'm giving you the right one. 237. All right. Page 237. Chapter 14. Care of pre-op patients. It's on the right side of the page. And it starts off at the second paragraph. The choice of laboratory testing before surgery varies among facilities and depends on the patient's age, medical history, and type of anesthesia planned. So the most common tests include, and you know, some of this is kind of common sense, a urinalysis, can tell us many things, right? Blood type and screen, patient may need blood. Complete blood count or hemoglobin and hematocrit, patient may be anemic, may require a blood transfusion. Clotting studies, PT, INR, PTT, platelet count. You don't want the patient to bleed to death or have develop clots. Also electrolytes like a BMP, basal metabolic profile. We're also looking at the serum creatinine and BUN. And depending on a female's age and the nature of the planned procedure, a pregnancy test might be warranted. Makes sense. I mean, if it's a 30-year-old woman getting ready to have major surgery. So go ahead and read the rest of that information. It starts off with urinalysis is performed to assess for abnormal substances in the urine. So go ahead and read the rest of that. And you can stop at just before imaging assessment. It's just a little snippet of information, so not a whole lot. So those are your labs to be aware of. Let's see. So the next concept is multiple sclerosis, urinary retention. That is in volume 2 of IGI, page 892. 892. Let me say this to you too. Let me check something real quick before I say it. Anytime I start quoting pages pages above 640, then we're in volume 2. Just a quick note about that. So 892, volume 2. Well, you know what? So, all right, so I said 892. 892. But actually, it's 893, but it doesn't have a page number. I think that's why I did that. It is actually a concept map on multiple sclerosis. So take a look at that concept map. That's what I should have referred to it as. But I guess technically it's 893. Because the next page is 894, but it doesn't have a page number. So take a look at that. In particular, on the right side of the page under patterns of elimination, it talks about assess for urinary hesitancy, dribbling, incontinence, urgency, and constipation. Use a bladder scan to assess for urinary retention. Implement necessary interventions such as catheterization, because the patient may be retaining urine, so you may have to perform a catheterization to empty the bladder. A bladder pacemaker, and this helps them to control their sphincter better. Or drug therapy might be used as well. Use best practices to prevent hospital-acquired UTIs. Promote urinary continence and bowel evacuation. Dysfunction can have a major impact on quality of life. So make sure you take a look at patterns of elimination in the middle of the page on the right side of that concept map. Let's see. And also, if you all can just take a look at your pathophysiology for MS as well. And that shouldn't be much information on that, but I would take a look at that. I don't have a page number, but some of your neurological disorders. All right. And heart failure, and the concept is heart failure dash activity of plan of care. I don't know if this is plan of care or point of care. Take a look at page 702. We're going to go on a break here shortly. I don't want to burn you out. Let's see. So 702 in volume 2. So you all already know that with heart failure, there's going to be a compromised cardiac and also respiratory issues. So the expected outcome are that the patient will have decreased fatigue and gain energy as their heart failure improves. Now, the patient in severe heart failure, now listen to me good, they're going to require initially now, they're going to require physical and emotional rest for energy management. So for the first day of hospitalization, you don't want to be getting the patient up, making them run around, move around, and making them exhausted and worsen their condition. So on the first day of their hospital stay, the patient just will be sitting up in a chair for their meals and just basically performing leg exercises while they're out of bed. This can also prevent DVTs. So they can perform leg exercises. You want to also organize your nursing activities to allow periods of rest. So you don't want to be constantly going in a room doing things because you're not allowing the patient to rest. So just make sure you kind of group your activities together, maybe give them medications, do the assessment, maybe help them on the bedside commode or whatever the activity is, but just try to group it so that you will allow maybe a few hours of just rest. These patients should also be referred to cardiac rehabilitation. And so go ahead and read the rest of that section on decreasing fatigue. Read the rest of that, it's not long, and you can stop at preventing or managing pulmonary edema. So it's not a lot of information here either. All right, so that's heart failure. You know, they have impaired gas exchange. They can't oxygenate very well. Fluid is backing up into the lungs, and so that will have an impact on their activity level. Emphysema. Emphysema is the next concept, and they're talking specifically about the medications the patients are on. And this would be on page 572 in volume 1. 572, volume 1. I think, wait a minute. Actually, try 579. All right. On the left, on 579, left side of the page, and it does talk about a stepped, it's the second paragraph down, stepped therapy, which adds drugs as COPD progresses. It's recommended for patients with chronic bronchitis or emphysema. Although the patient's response to drug therapy is the best indicator when drugs or their dosages need changing. So depending on how the patient is doing, if they're doing better, then you may be decreasing the dose. If they're not doing so well, then you might be increasing that dosage. We want to also teach these patients how to use their inhalers. That's a very important task to teach them. All right. Yeah, and read that section where it talks about many inhalers. It's the next paragraph. Many inhalers for COPD is the third paragraph on the left side of the page. Many inhalers for COPD drug therapy are dry powder inhalers, or they call it DPIs. These often require having the patient load in each dose. The steps for this process involve opening the inhaler's capsule chamber, removing the dry powder capsule from a blister pack. With this one, I will go ahead and do open up a YouTube video, and hopefully they can show you a demonstration of how to do this. But again, it's the second and third paragraph. I want you to read that for emphysema medications, and they do a lot of inhalers as well. So that'll be important. Also, well, the next one is eczema trigger. What triggers eczema? Eczema, excuse me, eczema. Page 462. 462. And I'll just have you to read this one. Read chart 25-7 on page 463. More particular, it talks about non-specific eczematous dermatitis. Read that, read about the distribution of this skin disorder. And also on page 462, where it talks about common inflammations, read pathophysiology. Read the pathophysiology. It's about 4 paragraphs, but they're really short. So take a look at that as well. They typically call it eczema because they really don't know what it is. It's not always known, or the specific cause is not really known, so they may refer to it as eczema. So make sure you take a look at that. 462 on the common inflammations on the pathophysiology. That's all I'll say about that one. Also, see, we'll do this. This will be the last one until, and then we'll just go on a quick break. Diabetes, and more specifically, blurred vision on page 1284. I tell you, you know what? It keeps it rather interesting because you have to go from one book to another. So that should keep you well awake and hopefully engaged. You're not just in one book. um, yeah, they're not keeping it boring at all. So have all those books right there at that desk with you and do your thing, right? All right, so and on page 1284, on the right side of the paragraph, excuse me, right side of the page, it's, let's see, one, two, three, four, the fifth paragraph down, and it starts talking about hyperglycemia may cause blurred vision, even with eyeglasses. Now, this is very important because hypoglycemia can cause temporary vision changes. It is important to wait until the blood sugar levels are normal before assessing refractory changes. So, when your patient, well, the high blood sugars has an effect on the eyes vasculature, and the higher the blood sugars, the more it will cause blurred vision, right? And so, you don't want to check the patient's vision until you normalize that blood sugar because blurred vision can be also caused by a low blood sugar. So normalize it first, then check the patient's vision, and you get a much better read on what their vision is. All right, so take a look at that. Just that little section, that one paragraph, just take a look at it. But it's the high blood glucose levels that causes the blurred vision because it has an effect on the vasculature of the eyes. All right, folks, go ahead and go to break and come back at 8:40. We will resume with cystitis assessment on page 1357 if you want to just turn to it just in case. 1357, cystitis or UTIs. Ms. Cameron, are you finding this information helpful at all? Yeah. You have to go back and still read, some more, but, just trying to bring out some of the highlights for you all.
Yeah, I think it's
Yeah. As I mentioned, you all will have time to, work with it yourselves.
So tomorrow, yes, do we arrive at campus at 9:45 and all that good stuff like we did last week?
Is that what time they told you to arrive?
Last week we did for our test starting at 10, yes.
Yeah. Yeah, that's fine with me. Just give yourself time. It's early in the morning, so it's not like you'd be going into any crazy traffic.
Right.
Have you guys registered already?
That's what I was just about to do. I haven't.
All right. You can do it on, when I release you all, which would be pretty shortly. Let me see how much I have to go. It's not a whole lot. If I can get to that point, I'm gonna stop right there, and then we'll do the rest when I come back. But let me mark myself. Let's see. All right, so is everyone back? Everyone on? All right. All right, so as I mentioned, the next concept is cystitis, hyphenated assessment, starting on page 1357 to 1358. If you take a look at 1358, chart 66. Oh, let me see. Thank you. All right, so I haven't stopped this one yet. Now I'm going to stop recording once I send you off to break, and then I'll re-record. So there'll be two videos. Try to make them short as possible. But thank you. We are recording. Let's see, cystitis. So on page 1358, chart 66-9, UTIs, it talks about common symptoms, frequency, urgency, dysuria, hesitancy or difficulty in initiating a urinary stream, low back pain, nocturia. So just go ahead and read the rest of that information. Also read symptoms that may occur in older adults. Says the only symptom may be something as vague, and that's the key, vague. These are older patients. Their immune system does not operate as well as a middle-aged person or a younger person would, because their immune system is deteriorating. They're getting older. So the symptoms can be vague as increasing mental confusion or frequent unexplained falls. Very important with the older population. A sudden onset of incontinence or a worsening of incontinence may be the only symptom of an early urinary tract infection in older adults. So patients with fever, tachycardia, tachypnea, hypotension, even without any urinary symptoms, can be a sign of urosepsis. Loss of appetite, nocturia, dysuria are common indications. So make sure you read that. That's a great chart, for you to read. Also on page 357 under assessment, more specifically, physical assessment, signs and symptoms. Read those paragraphs. Let's see. Read the first three paragraphs and they're very short. Yeah, so take a look at that information. All right, moving on. All right, the next concept is COPD interventions. And in volume 2, excuse me, volume 1. Volume 1, starting on page 574. I hope. Actually, scratch that, 575. This is one of those where you have the concept map. So if you look on the page 574, 575, it doesn't have a page number, but it is the next page after 574. On the nursing priorities in the middle, on the right side of the page, but in the middle, it talks about nursing priority, and it talks about improving gas exchange. So teach patient to participate in COPD management, airway maintenance, breathing techniques. Remember the pursed-lip breathing, positioning, effective coughing, oxygen therapy, exercise conditioning, suctioning, hydration, use of a vibratory positive pressure device, and adhering to prescribed drug therapy. This promotes airway maintenance to improve gas exchange. And read the rest of this information as well. Talks about things like assisting the patient with strategies to manage anxiety. You know, when you can't breathe, you become very anxious, right? Teach the patient to avoid crowds, get the pneumonia and influenza vaccine. And this prevents prevents risk for respiratory tract infection. So read the rest of that information. Again, nursing priority, that's the heading, improving gas exchange. These are some interventions. And also read, and these are short too, interpreting laboratory assessment. May have to obtain an ABG. You also may have to obtain a hemoglobin, hematocrit, assess the electrolytes, and what have you. Also drug therapy, a header. Just make sure you read that information as well. It's not that much. It's like a couple of sentences, actually. All right. And on that same page, go ahead and read expected outcomes as well. And that's not much either. Let's see. I had something on 588, but I'm not sure what that was. I'm not sure why I have 588 there, so I won't worry about that. So the next one is next concept, acute rebound abdominal pain, which is in volume 1. Yeah, volume 1, page, starting with page 588. That doesn't look right. Oh, you know what? Wait a minute. 588. Let me see something, because sometimes I forget the right fundamentals. 588. All right. Anyway, so for acute rebound abdominal pain, go to your fundamentals book, textbook, and look on page 588 to 589. This, I don't know, I have volume 1. Yeah, so there's no volume with this one. Page 588 to 89. Um, Start on page 588 with palpation and read that. Read those few paragraphs and really focus on the last paragraph. Talks about, it starts off with survey each quadrant systematically. You're palpating or feeling for masses for size, location, shape, consistency, tenderness, pulsation, and mobility. And it also talks about rebound tenderness occurs in patients with peritoneal irritation, such as appendicitis, pancreatitis, or any peritoneal injury causing bile, blood, or enzymes to enter the peritoneal cavity. So read that section as well. Not very long. The next concept is urolithiasis, more specifically lithotripsy. And take a look at volume 2 of IGGI, starting with page 1364. 1364 of IGGI. And on the left side of the page, down at the bottom, it talks about lithotripsy. Sometimes they place this anesthetic cream on the side where the ultrasound or the device will be in contact with the patient's skin, because it will send these shock waves that actually breaks up the stones. And they may apply this cream 45 minutes before the procedure, so it can absorb, so the skin can absorb it and you can get that anesthetic effect, right? During this procedure, these patients are also placed on a monitor, a cardiac monitor. You're checking for any dysrhythmias. Also, once you do a lithotripsy, you want to strain all urine to monitor for passage of any stone fragments, because they do, pass fragments, stone fragments. These patients might have a bruising on the flank area or side. So you want to check for bruising or discoloration of the skin after this procedure. And I also said 1366. So on page 1366, chart 66-11, talks about urinary calculi, and down towards maybe the middle, it starts off with expect bruising after lithotripsy. The bruising may be quite extensive and can take several weeks to resolve. The reason that is important is because you may have to, I don't know why this person keeps calling me from Ponte Vedra. Anyway, so the bruising, I was saying that the reason why this is important is because you may have to explain to your patients, as far as teaching or education, because they may be concerned, about this bruising, and you have to tell them how long it will last, and kind of allay their anxiety or concerns. Also, your urine may be bloody for several days after, actually, I don't know if this is, not surgery. So, all right, so let's just stick to the one where it talks about expect bruising after lithotripsy, and how you want to explain to your patients that it can be extensive and last for several weeks. Yeah, we'll stop right there with that one. Let's see. Rheumatoid arthritis plan of care, starting with volume 1 of IGI, page 321. Somehow I don't think that's right. Seems like that was in another book. Well, maybe not. Oh yeah, yeah, that's right. Yeah, so rheumatoid arthritis starts at page 318, and want you to look at starting with page 321. These the interventions. So what I want you to do is go ahead and look at starting with the right side of the page on 321, managing chronic inflammation and pain. Read that information. It's interventions. Also read page 324 regarding promoting mobility. And you can read about its interventions. You can also read about enhancing self-esteem and its interventions as well. So that'll be page 321 to 324, and stop with enhancing self-esteem after you read those interventions. It's not really a long read, but I would like for you to be familiar with the interventions related to rheumatoid arthritis. All right. Now, there's one on here that talks about joint pain and weakness, and that's really vague. And so I don't know which direction to go with that one, other than, pain management, and depending on the cause of the weakness, just more supportive care for these patients. So I don't really quite know what they're looking for. But something to just consider, as far as pain management and supporting the patient, safety, and what have you. The next one is IV. It talks about IV and then units per hour heparin. So take a look at your calculations textbook and see if it will give you some information about heparin. More specifically, they may provide you with an example of how to work out a problem with IV heparin. I meant to check my calculation book last night to see if I thought I saw something in here a while back. I can't be sure. You all should have this book. $121. Let me just see if there's a calculation in here. $121. 121, 123. $476. All right, so in your calculations of drug dosages, I would imagine you all have this. I don't know if you all can, let me turn this off. Let's see, shows background effects. All right, so this book here, I would imagine you all have this book kind of backwards, so the words are backwards. So go ahead and take a look at that one. And starting on page 479, it gives you several methods from which to, work out your heparin problems. So make sure you get familiar with that section. Page 479, and the author is, I guess that's Fluharty, Linda Fluharty, the 7th edition, and Sheila Ogden. All right, so that's your heparin. What page did I say that was again? 479? I think that's what I said. I meant to write it down. Yeah, is that all right? I meant to write it down and I didn't, so I wanted to make sure I, did that. So 479, make sure you take a look at that formula. All right. So I'll be sending you guys on break here shortly. Well, for your own study time. All right. So the next one is Guillain-Barré, or sometimes people call it Guillain-Barré syndrome. And this talks about, there's a concept, Guillain-Barré blank. So think about the muscles of the eyes. So the abnormalities of the blink reflex most likely represent demyelinization in either the facial or the trigeminal nerves, reflecting the multifocal nature of demyelinization. So basically, the axons, they have that sheath that covers them and protects the axons. And when you talk about demyelinization, it means that the myelin sheath is being destroyed, exposing the axons. And of course, this can cause the nerve to actually be exposed and become affected to where the patients don't have a good, a normal blinking reflex. In your IGGI book on page 912, volume 2, volume 12, excuse me, volume 2, page 912. So if you start on page 912, that's when the conversation about Guillain-Barré syndrome is discussed. And let's see. Yeah, so on page 914 in particular, under interprofessional collaborative care, assessment or noticing, your physical signs and symptoms, and it will begin to talk about the different cranial nerves. Go ahead and read that section and stop at diagnostic assessment, just a few paragraphs. And also read the chart on page 914, chart 44-1. Read the signs and symptoms, the motor, the sensory, cranial nerve manifestations, and autonomic manifestations as well. Just take a look at that information as well. Let's see, GERD. On page GERD, and more specifically instructions. That's the concept. GERD instructions. So page 1090. Yeah, 1090. So on page 1090 in chart 54-2 talks about patient and family education, preparing for self-management. This is what your education is all about, so you can help these patients manage their condition better. All right. So it talks about you instructing your patients to eat 4 to 6 small meals a day. You don't want to overwhelm the GI system. And it's easier to digest, of course. Limit or eliminate fatty foods, coffee, tea, cola, chocolate, in other words, caffeine. Reduce or eliminate from your diet any food or spice that increases gastric acid and causes pain. Limit or eliminate alcohol, tobacco, and reduce exposure to secondhand smoke. Do not snack in the evening, and do not eat for 2 to 3 hours before going to bed. So go ahead and read the rest of that information. It's pretty self-explanatory. These are instructions that you would give your patients who have GERD. All right, folks, just a few more to go, so bear with me. All right, this other one talks about DM, and I'm thinking this is talking about either diabetes or the, could also be talking about the, the expectorant, the guaifenesin, the cough medicine. But I'm going to go with diabetes for now because it talks about DM, upper respiratory infection. So here I want you to think about how diabetes has an impact on the immune system and how it can lead to URIs, upper respiratory infections. So people with diabetes, they are more susceptible to developing infections because the high blood sugars can actually weaken the patient's immune system, system's defenses. So in addition to what I just talked about, some diabetes-related health issues, there's some other ones that, such as nerve damage, reduced blood flow to the extremities, and increase the body's, this increases the patient's vulnerability to an infection. All right. So just know that when patients have diabetes, it does affect their immune system. Just like renal failure, it affects their immune system. All right, so that's all I'll say about that.
Did you have a pacemaker?
I actually don't. I'm just going off of what I have read about that from, I guess, some years ago, and knowing the effects of diabetes on the system. So I just kind of wanted to give you an idea where it's going.
On page 83, it talks a little bit about the excess acid caused by absence of insulin, and it talks about Kussmaul respirations and stuff. So you might want to look at that page.
Kussmaul respiration. I think I saw that. Page 83 in what book?
1283 in volume.
1283. Yeah, I think I saw that one. Yeah. Yeah, now the Kussmaul respirations, if you were to look that up, basically these patients, they're trying to blow off, or they because of the diabetes, they have a lot of acid, they're acidotic. And so they're trying to blow off the CO2. Yeah, so yeah, go ahead and just read on page 1283 on the left side of the page, probably 5 paragraphs down, starting with the excess acid caused by absence of insulin release, hydrogen ions, and carbon dioxide level in the blood. So yeah, you can go ahead and read that part as well. And stop at acute complications of diabetes. That's acceptable too. As far as cancer, intractable pain, plan of care, page 46 in volume 1. Go ahead and read, let's see, starts on page 47 under the heading chronic pain. Read that one. Read chronic cancer pain beneath that. All right, and just stop at chronic non-cancer pain for that one. And intractable means you can't get any relief. No matter how much pain medications you're giving the patient, that thing won't disappear. All right, yeah, so yeah, so intractable pain, you're giving all these opioids, all these analgesics and what have you, and the patient still has pain. All right, so just take a look at that information. The idea here is to control the patient's pain, and don't worry about the patient becoming addicted to the pain medication. Because here's the thing, I mean, studies have found that when patients' pain is well controlled, they actually have an extension. Let's say if they're in a situation where they're terminal. If they're in a lot of pain, they're not going to live much longer after that. But if they're provided palliative pain therapies, they tend to last, I think the number is maybe 6.5 weeks longer. So they live a little longer, because pain has some pretty deleterious effects on the body. So keep that in mind. I did not find anything on biopsy prep, but with this one, once you get your biopsy, you may place the specimen in what we call formaldehyde, about 10%, and they send this off for analysis. You want to also make sure you're checking your patient's vital signs, provide as much analgesia as needed, because the patient might be in pain from the biopsy. You want to observe and report any bleeding, any tenderness at the biopsy site, and also provide emotional support to the patient who is awaiting a diagnosis. Think about in this respect, think about Kaposi sarcoma and having to have a biopsy done. And I have no page number, but that information is a little rather general, I reckon. All right, so just have a few more to go here. AAA, abdominal aortic aneurysm, very large artery, and it talks about post-op, page 740. So that would be in volume 2 of Iggy, I think. 740. We're getting there, people. When I stop this recording, remind me to tell you something about EAQs and a conversation. I don't want to put it on here. All right, so on page 740, on the left side of the page, starting with, I think the third paragraph down, where it says most patients are discharged to home after aneurysm repair. And then read that, down to if discharged to home, the patient must follow instructions regarding activity level and incisional care because stair climbing may be restricted initially. So just read all that information. All the way down, you can stop at aneurysms of the peripheral arteries. So just a few paragraphs, not very long at all. And with this one, when we're talking about post-op care, these patients are at increased risk of bleeding. So you're certainly observing their vital signs, pretty frequently, maybe every 15 minutes, observing for things like hypotension, bleeding at the site, tachycardia, shock symptoms is what you're looking for. Read about these activity restrictions on these patients who are having these surgeries, this type of surgery. A lot of the patients used to die. There was like, I want to say close to 80%, as far as chances of them not making it. Yeah, it was pretty high. 20% chance of survival, in other words. So that's pretty bleak numbers. All right, so what I also want you to do, this is, I didn't provide page numbers for this one, but I actually talked about Trousseau sign in my notes. I want to say around the parathyroid disorders, or you can also do a YouTube video on Trousseau sign. Trousseau sign tests for latent tetany, and it's most commonly positive in the setting of someone having a low calcium level, a hypocalcemia. And so what they basically do is put a blood pressure cuff on a patient's arm. They increase the pressure about 20 millimeters per mercury over the systolic blood pressure. So if a patient's systolic blood pressure is normally 130, they'll increase it to about 150, and for about 3 minutes. And then if you see these spasms, then it's a sign that the patient could have low calcium. You certainly want to go ahead and draw your calcium levels. Because you may have to replace the patient's calcium levels because they can die. It's a medical emergency. So that's Trousseau sign. The other one is Shostak sign, but they don't seem to be asking about that one. But the reason I'm saying that is because I don't want you to confuse the two. Trousseau sphygmometer. Trousseau sphygmometer. Because remember, the Shostak sign is when you're tapping the patient's facial nerve and you see the twitching. Not that one. We're not looking at that one. But don't confuse that one with Trousseau sign. Like I said, that one is in my slides as well. Should be parathyroid conditions, especially when you have to remove the parathyroid gland. They're prone to or susceptible to experiencing low calcium levels. And so this is just an early indicator, allows you to detect this problem early. Remember, in nursing, we're always trying to look for early signs. In your fundamentals book on page 887, oh yeah. Now hold just a minute, folks. Let's see. So the next concept is thoracentesis, positioning. How do you position a patient for thoracentesis? And if you look on page 887 in your fundamentals book in table 41-5 and down several headings, it says thoracentesis. And it says patient usually sits upright with the anterior thorax supported by pillows or an overbed table. All right. So go ahead and read that. It's very short. Thoracentesis and of course the interpretation and purpose. Read that information as well. Very, very short. Fundamentals, page 887. It's in a table. And we're more concerned about the positioning, proper positioning. Well, the next concept, just a few more to go, y'all. Skeletal traction is the next concept on page 1040 in volume 2. So on page 1040, on the right side of the page, it talks about traction. It tells you what traction is for. It's a pulling force to the part of the body that to provide reduction, alignment, and rest. It also, it's a last resort to decrease muscle spasms. Muscle spasms can be very painful with a fracture. So it actually gives you enough pulling force to decrease the muscle spasms. You want to make sure you're doing pen care on these patients. They have these pens in place. Do pen care in order to avoid infection. You're documenting, of course, the information as far as any drainage, describing the site and what have you. You're doing neurological checks on these patients. You're inspecting the traction equipment, which consists of like a rope, a knot, and pulleys, and you're checking that every 8 to 12 hours for any loosening or fraying of the rope or positioning. You want to always check the weight that is applied. Sometimes, depending on the weight, if let's say the doc may order 5 pounds, make sure it's 5 pounds. Sometimes, the weight is too heavy and causes excruciating pain. So you want to make sure that there's enough weight, but not too much. So just take a look at that. The right side of the page on traction on 1040 and also 1041 on the left side of the page. Just finished it up and stop at drug therapy. Not a whole lot to read on that one. All right. Sometimes the patient's weight is actually used as counter traction. So with the patient's weight, they're like in a certain position in the bed while the weight is pulled in an opposite direction. But it does provide some relief to the patient. Let's see. So take a look at that. 2 more until we come back. Then it won't be as many, actually. That's why I was trying to go through it quickly. Or try to get as much done, I guess I should say. So page 422, volume 1 in your IGI, 422, volume 1. On page 422, left side of the page, methicillin staphylococcus aureus, or MRSA. Please go ahead and read that section. all the way through community-associated MRSA. And on the right side of the page, that little section, and you can stop where it says NCLEX examination challenge. Stop right there, but just go ahead and read that section. One thing to keep in mind, it talks about studies show that bathing patients or hospitalized patients with pre-moistened cloths or warm water containing chlorhexidine, gluconate, or they call it acronym CHG, change, solution can significantly reduce MRSA infection. And take a look at, when you look at a YouTube video on the chlorhexidine gluconate, it's like the maybe fourth paragraph down, and it'll show you those little packets that they use. And because, you know, we used to, and they probably still do, I'm sure, in different cases, but they, it's in like a burgundy pack, and you warm them up, and you wash each arm, each leg, each different body part. You never put it on the face though. And this cuts down on MRSA, you know, infections because of its antiseptic effect. So make sure you take a look, do a YouTube video, take a look at how they actually wash these patients. I won't take up your time with that information. All right, so take a look at that. So the last one I want to look at before we let you, you can go ahead and take a 10-minute break and then just start looking at your information. We'll meet back up at 3 o'clock, and just make sure you, you know, take a lunch, you know, maybe from 11 to 12, and do what you have to do. Remember, the more you do now, the less you have to do tonight. So the last one is prostatectomy catheter leaking. That is on page 1488. You know, when these patients have a prostatectomy, they're going to have a catheter for probably several days, maybe a couple of weeks or so. And so leaking around the catheter, this is pretty common, especially when patients are up walking around, and also when they're having a bowel movement. You know how when you're having a bowel movement, I know too much information. When you're having a bowel movement, and the reason I'm saying from our personal experiences, you feel like you have to also urinate while you're having a bowel movement. So one of the best things I say that you can do to help a patient not urinate around that catheter is to try to tell them, you know how when you have to go and pee, and you're trying to hold your pee, you know, like voluntarily and deliberately. So, you know, just tell the patient just to hold, like, make sure they're kind of like holding their pee while they're having a bowel movement. That'll prevent that leakage, a lot of it, you know, so that's my recommendation. Let's see. So walking around, as I mentioned, you may have some leakage around the catheter and possible small amount of blood around the catheter as well. When this happens, let me back up. So sometimes if it's leaking like that, you may have to instruct your patients to wear Depends, diaper. We don't like to call them diapers, but Depends. We call them Depends. So you may want to recommend them wearing a Depends. So if your catheter also stops draining, you want the patient to lie down flat and drink lots of water, and this will flush it out because it could be a blood clot. So you want to flush your kidneys out as much as possible. So just make sure that you're watching for any blockage, as well as any leakage when they have these catheters. All right. didn't really give me a whole lot of information on leakage or prostatectomy. But just because you have a Foley catheter, it doesn't mean that you're not going to, have leakage of urine. All right, so this is where we are now. That didn't take too long, maybe a little over a couple of hours or so. So what we would do is we'll come back at 3. I want you to go ahead and, be diligent, take a look at this information. You have tomorrow. It's the big day. I don't want you guys taking this test lightly, because if we don't know where your weaknesses are, then what is the point of remediation? So if you really give this thing your all, then we know where you are, and we remediate. Then for your final HESI, you can really jack those numbers up, pass this class and move on. So we'll come back at 3. We'll start off with pernicious anemia and just finish off the rest of this, which is pretty short for the most part. So that should make you feel a little better.
What were you going to do? EAQ.
Oh, hold up, let me. I want to make sure I stop recording.